currently our community transport option in Northern Ireland, which would be a lifeline for many older people across Northern Ireland in rural communities. Various different community transport organisations, they all were under threat of losing their funding, which would have meant the whole community transport network would have closed down. Meaning that people wouldn't be able to get to visit family, wouldn't be able to attend hospital appointments, wouldn't be able to get into their local towns for shopping, for necessities, and it really is a lifeline for them. So if we lose services like that, that has an ongoing impact on the health and well-being of our older people. And impacts the health service in the long run, because those older people will not be able to stay at home in their own homes for as long as they want to. They may need extra care, they may have falls and end up in hospital for long-term stays.
It has really opened my eyes. As I said, a lot of our training as clinicians is very focused on the person. So the biology, the pharmacology, the physiology, the anatomy of the person. Medical training in my setup does not focus on the system. And I think that's where the disconnect happens, that as a clinician, you focus so much on the person, you do not remove yourself from the person to where the patient is located. So like, for example, does the patient come from a minority group? Is the patient able to access the hospital, even in terms of transport, for example? Can the patient reach the hospital? Does the patient have family carers or a social support system that can help them cope with their condition? I think you can only understand a patient fully when you understand their context.
The pandemic period, we had limited access into communities, into hospitals, or even into homes of patients. And using telecare technologies or other age tech devices, this became possible. We had to do a lot of education, and we also had to work with the manufacturers and providers to make it not only user-friendly, but age-friendly and family-friendly. And now with artificial intelligence, on the one hand, it's becoming easier and more efficient for frontline care providers to get help in developing an integrated care plan. However, it's also creating new barriers for people or regions that have had less exposure to such technology.
Conocimiento de los derechos sexuales y reproductivos de las mujeres, empodera a las mujeres con el conocimiento, la empodera en una cultura de exigibilidad de derechos, y entonces esto obliga a los prestadores de salud de dar servicios de mayor calidad con una perspectiva de atención integrada. ¿Qué derechos sexuales y reconocidos? El derecho a estar acompañada, el derecho a tener la evacuación de dudas de su proceso de salud de enfermedad, el derecho a estar informada, el derecho a pasar con la persona que ella quiere escoger, nuestras pacientes. También empezamos a ver cómo se transformaban las usuarias desde un sujeto pasivo de atención en un sujeto activo de atención, que participaba activamente de las decisiones sobre su salud y se respeta a través de un plan de parto.
I was admitted for surgery as my appendix had ruptured. And this was a really scary time for me. And I was relieved that the healthcare team around me just arranged everything that I needed at the time when I really didn't know what I needed, as I was too overwhelmed with the level of pain and emotion. However, if you have a chronic health condition, it's a very, very different experience. There is no integration. There are silos and barriers. These words I've learned since becoming a health consumer advocate in Australia. Barriers to me with my consumer eyes on means offence, or they're put there to crowd control. And I've never really been able to grasp the reasoning why a health and social system would build a fence. Trying to navigate the health system for my loved ones feels very much like landing in a different country with a different language, a different culture, without a map, a navigation aid of some sort, when you're not feeling yourself uncomfortable at perhaps one of your most vulnerable points in your life.
Good morning. It's a pleasure and an honor to welcome you, to give you a warm welcome at this conference, also on behalf of the scientific committee that I had the honor to chair in preparing this conference. A conference as this has three dimensions. First of all, there is the preparation. Everybody is working, is preparing, is giving his evidence, is producing abstracts. And that's a very important part. The second part is now. We have interaction, we are meeting, both in person and virtually. Of course, very important, because that's the place where new ideas will develop and flourish. And then there's the third part, that is looking at the legacy of the conference. What difference did this conference make in our own environment, in our country, in our organization? And how can we try to make sure that also the people in the neighborhoods, the people in the community, take advantage of this conference? So we are now in this important second part. Just to introduce myself, I'm a family physician by training, and I worked for 40 years in interprofessional community health centers in one of the most deprived neighborhoods of the city of Ghent, which is a neighboring city more or less 50 kilometers from Antwerp. And there I've been confronted with the challenges of care and integrated care. And at the same time, I had the possibility to do academic work as the chair of the Department of Family Medicine and Primary Health Care at Ghent University. Actually, amongst other tasks, I'm also involved in the WHO Collaborating Center on Family Medicine, Primary Health Care at the Department of Public Health and Primary Care at Ghent University. As a short introduction for this session, and I hope we can have the next slide. Yes, okay, that's great. Just a few words. I think integrated care is a means, it's not an end. And that means the focus of integrated care is always the person. How can we make the person's life worth to be lived? How can we make sure that the patient can value his life? How can we integrate his values in the choices we make together in order to restore and improve health and well-being? And I just want to introduce you to a short journey about what in the last 70 years has been the thinking about person-centered care. All disciplines in health and welfare care have contributed to the search for strategies and methods to put the person with a need for care and support at the center of their interventions. Let's take a short walk in history. And history, of course, already started very early because it was Hippocrates himself in the island of Kos, 460 years, next slide please, before Christ, that already focused on the person and said, we need the person as the center. And also, when we were 1950 and Carl Rogers in the United States published his book on client-centered therapy, we saw that in different disciplines, because that was not only about medicine, it was about people with problems. People were looking for putting the client, the person, the patient, whatever the name, in the center of the approach. Next slide, and also Carl Rogers was followed up by many others. In Switzerland, there was Paul Tournier, who was also a medical doctor, and he focused a lot on spiritual and psychosocial aspects of care. And I think that are dimensions that also will be present in this conference. Next slide. In 1961, there was this famous book by Thomas Szasz, The Myth of Mental Illness. And it was the start of a series of reflections on mental health. And I think that I don't tell you something unknown when I say to you that still today we are looking for ways how we can address best mental health problems. And of course, recent times have confronted us with an increase of those problems in our society, and especially also with vulnerable people and with young people. Think also about the impact of long COVID and other things. So we are still reflecting on how this mental health aspect can be integrated. Next slide. But there was also social movements that have inspired our working together in the care system. The patient participation, you can say, is a spin-off of the emancipatory May 68 movement. But there remain still many important domains to be developed. Think about patient advocacy group. We have some testimonies in the movies some minutes ago, but also the translation into the legal system of patient rights is still something that is developing in most of the countries. So there's still a lot of work to do, but this kind of participatory movement has always been also a component of integrated care and working together. Next slide. In 1977, Ivan Illich wrote his famous book, Medical Nemesis, writing a kind of criticism to the way health and care were developing. He wrote that he was seeing and observing a kind of expropriation of health and welfare. Health was taken over by technology, by institutions, by hospitals, and that was leading to alienation of people from their health, from their well-being. And he also said, well, we have to change that. We have to look for new values. We have to bring people together. The health system and the care system has to be bringing people together in social cohesion. And this wonderful book, those Tools for Conviviality, that's mentioned there, give some, even today, very relevant ideas to make this happen. And he mentioned also the importance that it was not only something that happened in the Western world, this person-centered development. I had myself the opportunity to do consultations at primary care with all kinds of disciplines in all continents. And what struck me always was there is such a kind of uniform core of interaction with people that are in need. And whatever the culture, the country, the language, people in need, they feel same and similar things. They express them differently, and that's exactly what we want to focus on when we try to make the care better and to integrate the care. In the same year, next slide, Engel wrote his famous article in Science that there was a need for a new medical model, a change for biomedicine towards a biopsychosocial model. And I think that's also something that inspired a lot of our developments. And today we even add the eco to the eco-biopsychosocial model. I think it's an important cornerstone in what we did. In 1978, there was the WHO, next slide, Declaration on Primary Healthcare in Alma-Ata. And apart from the fact that it was a very clear visionary text, it took 30 years before also at all the levels we had the conclusion that primary care should put the people first. It was in the World Health Report 2008, the third chapter, that for the first time very clear WHO and all other international organizations had put the emphasis and the focus on putting people first. Next slide. In the late 70s and in the 80s, nurses, social workers, family physicians, you all developed communication strategies focusing on the person, avoiding reductionist framing. And we learned to make a broad intake, putting the question forward, why does this person visit me, a nurse, a social worker, a family physician? No, with this complaint, concern, ID, question, emotion, as being, that's the definition from the start of a care process. And then we go the journey together with the patient and with the person in front of us. More and more teams started to take advantage of international approach. And then, in the beginning of this century, we saw that it was very needed that we went for a paradigm shift. We were faced with multimorbidity, and we saw then that it was even more needed to focus on a person-centered approach. And how we did that, Carolyn Steele will lead us through that journey. And I cross the ocean now, and Carolyn will join you and come here.
Grab our clicker, because we're going to be in conversation with Jan and Jim Mould, who's going to be joining us virtually. So I'm just going to give a second for us to see Jim up on the screen. And I guess while we're waiting, I can introduce myself. I'm Dr. Carolyn Steele. I'm a research scientist from Canada, working in the space of integrated person-centered care and digital health, but have had the great pleasure of working in goal-oriented care with Jan and some other folks who you'll be hearing from this morning for some time. So we're going to be having a little bit of a conversation with Jan and Jim Mould, who was one of the first to kind of write about goal-oriented care back in 1991. And I'm just going to look to our back to see if Jim is with us. Oh, I see you. You're all the way over there. Hi, Jim. Nice to see you this morning. And I guess it's later in the afternoon for you. Wonderful. So thank you all for joining. Jim, I wonder if you can start us off. So Jan has taken us through a bit of a history with person-centered care, but how did you come to the initial idea of goal-oriented care back when you wrote about it in 1991?
Let me first thank Jan for inviting me to participate. I'm sorry I can't be there in person. However, hopefully my voice is coming through clearly, is it?
You sound great.
And I hope you won't be bothered or alarmed by my slightly bloodshot eyes, because it's 3:30 in the morning here, actually. In 1991, I was a junior faculty member in a Department of Family Medicine at an academic medical center. And because of departmental needs and my own personal interest, I'd become a geriatrician. I was taking care of older people, and I was developing curricula and clinical teaching sites, including sites at a rehabilitation hospital, both inpatient and outpatient areas of that hospital. And I was giving way too many lectures to community physicians on normal aging. I'd also gotten a grant to start a geriatric education center at the academic medical center, and it involved all the colleges, College of Medicine, nursing, pharmacy, dentistry, allied health, and public health. And within my own department, I was also working on developing a mentorship program for the residents, working with a specialist in adult education. So as all those things were happening, it struck me that everybody except me was talking about goals. And I began to wonder what it would be like if physicians focused on goals rather than problems. And the more I considered the idea, the more it seemed like It addressed a number of the concerns that I was having about how to provide humane care for older people. It seemed like such a simple, obvious, and rational approach. That is, you should clarify what you're trying to achieve prior to deciding how to achieve it. But when I took it to two of my faculty colleagues, they sent me directly to the literature on paradigm shifts. We were ultimately able to agree on a justification and some basic principles of goal-oriented care, and we wrote a paper that we sent to the New England Journal of Medicine, a very prestigious American medical journal, where it was soundly rejected by the editors without further review. It was eventually published in a journal for academic family physicians called Family Medicine. As far as we could tell, it had no impact whatsoever.
Well, you know, you say it had no impact whatsoever at that point, but I think we're going to continue through this journey a little bit, and I'm going to go to Jan next. And so you had a chance to hear about that. What resonated with you when you first read Jim's paper in 1991?
Absolutely, Jim, it had impact. When I was reading as a young professor in 1991, this article, I said, wow, this is it. This is what care should be about. That should be the starting point of our intervention. And immediately I integrated your article in my course for the fourth year undergraduate students. And they reacted very positive because it gave them an inspiration, a perspective. The question that is that you have to start from what really matters for the people. And that is the starting point of the intervention. And it was wonderfully described in the article that you made there. And also, we had already some expertise. In 1986, the Flemish government started little small steps in integrated care, bringing around the patient different disciplines together. So that also echoed well with goal-oriented work, because it is, as you said very correctly, it is about the goals. That's the starting point. So that was what we did. But also in our practice, in the daily practice, we could use that concept very well. And I just want to take you with a patient that the nurse and myself took care of in those days. Jennifer is 79 years old. 15 years ago, she lost her husband. She is a patient in the practice for 15 years now. During these last 15 years, she has been through a laborious medical history: operation for coxarthrosis with hip prosthesis, hypertension, diabetes type 2, COPD, osteoarthritis, and there is also osteoporosis. She lives independently at her home with some help from her youngest daughter, Elizabeth. I visit her monthly, and each time she starts saying, "Doctor, you must help me." Then follows a succession of complaints and unwell feeling. Sometimes it has to do with the heart, another time with the lungs, then the hip. The nurse is confronted with a similar scenario at her weekly visits to Jennifer. At each visit, I suggest, next slide please, according to the guidelines, all sorts of examinations that did not improve her condition. Her requests to the nurse and to me became more and more explicit, and our feelings of powerlessness, insufficiency, and spite increase. Moreover, we had to cope with guidelines that were contradictory. For the COPD, the chronic lung problem, she sometimes needs corticosteroids, which worsen her glycemic control and diabetes. The adaptation of the medication for the blood pressure, at one time too high, at another time too low, cannot meet with her approval, as does the interest in her fast hemoglobin and lung function test results. After so many contacts, Jennifer says, "Doctor, I want to tell you what really matters for me. On Tuesday and Thursday, I want to visit my friends in the neighborhood and play cards with them. On Saturday, I want to go to the supermarket with my daughter. And for the rest, I want to be left in peace. I don't want to change continually the therapy anymore, especially not having to do this and to do that." In the conversation that followed, it became clear how Jennifer had formulated the goals for her life. And at the same time, we as care providers felt challenged how the guidelines could contribute to the achievement of Jennifer's life goals. The nurse and I visit Jennifer again with pleasure ever since. We know what she wants and how much we can merely contribute to the achievement of her life goals. Ladies and gentlemen, do you know Jennifer? And that was what people all over the world in all continents said when they were confronted with the stories. They said, we know that person, we know that patient. And just one slide now. Look at the sum of the evidence-based guidelines for the person with this condition. We are not going into details. We have to perform a lot of clinical tasks around administer vaccine, check blood pressure, and so on, evaluate the status, laboratory tests. Then there were also some patient tasks, joint protection, energy conservation, exercise, not too much, not too less, sufficiently, wear appropriate footwear, and so on. Moreover, there was a patient education program the patient has to follow, all evidence-based, foot care, osteoarthritis, COPD medication, diabetes, and so on. And there were also referrals for physical therapy to the ophthalmologist, for the pulmonary rehabilitation. And last but not least, 22 intakes of 11 different medicines daily. Is there life apart from the disease when you have to do all this? So that was really the way that the inspiration that Jim brought us, we tried to put it into practice. And I did not have, next slide, to think one single second when they asked me to propose an article that would be published in the classic papers of family medicine. When Michael Kidd asked me, I said immediately, Jim's article on goal-oriented care. That should be published.
Thanks so much. So Jim, kind of hearing where the idea kind of resonated with Jan. Now it's been some years since that initial paper and moving into the family medicine paper. How has your thinking on goal-oriented care advanced since then?
Well, in preparation for this conference, I reread the paper for the first time in many years, and I was somewhat surprised to find that it still made sense to me. I still think it's a simple, obvious, and rational way to provide integrated care. But over the last 30 years, my beliefs have evolved. I've learned a lot from trying to sell the idea, particularly to physicians without much success, and from listening to all their counter arguments, and from my efforts to implement it in practice, which were, I think, fairly successful. Very rewarding for me, of course, and for my patients. And most recently, I've learned a lot from a number of believers and supporters, like the people on this plenary session. One of the things I have discovered is that goal-oriented care may not have been the best name for the idea. The trouble is that there are many different definitions of the word goal. And that has caused many clinicians to discount the idea, saying, of course, that's what we do, and we've always done that. But certainly you're talking about a different set of goals than what I had in mind. Patients also have trouble with the word goal because they find it too large to handle. And I almost never use the word goal in clinical encounters. It's not a useful term. But the name has been out there for too long now, and so I've recently been calling it person-centered goal-oriented care or goal-oriented person-centered care, because that emphasizes that the goals that we're talking about belong to the person seeking care and not to the clinician. Interestingly, in 2012, two American geriatricians, David Rubin and Mary Tanetti, who apparently hadn't seen the 1991 article, wrote a nearly identical article called Goal-Oriented Patient Care, an Alternative Outcomes Paradigm. And they published it in, wait for it, the New England Journal of Medicine. After discovering the problem with the word goal, I suspect, Mary Tanetti subsequently called her version patient prioritized care. So I've become much more aware of the importance of language and terminology in general, and I think that adoption and implementation of person-centered goal-oriented care will depend to a great degree on the development of a common language that's comfortable for both clinicians and patients. In subsequent publications, I've offered a number of suggestions with regard to that language, but much more work needs to be done. Could you change to the second slide? Hopefully you've been, I guess you weren't showing my slide, I suppose.
No, I'm showing your slides. We got you. Don't worry.
Okay, show the first slide that has my name on it.
This one?
There's a slide that has my
making
name
it work.
and contact information on it.
Well, I think it's all the way at the front, so we're gonna hang out at the goal type slide if that's okay, and then we'll go forward to the process slide.
Oh, okay, that's fine. I think there are 4 different types of goals that are relevant to health and healthcare, actually to life in general. The first is survival. The second is quality of life and personal growth and development, and a good death. I think those are universal life goals, I believe, and they're all very relevant to healthcare. I think categorization is actually helpful for several reasons. The first is that because the processes and the strategies of clarification and achievement of those 4 different types of goals tend to be somewhat different. At least they were as I implemented it in my practice. So I think it's useful to think about them in that way. I think also categorization makes the trade-offs between the different types of goals more obvious. And trade-offs can be quite important. I also think that those 4 different goals tend to assume greater importance, different ones of them assume greater importance at different stages of the life cycle. And I think that patients, clinicians, and other care providers of different types have more to contribute to some of those goals than to other goals, and it's helpful to acknowledge that. So, for example, occupational therapists and palliative care clinicians already practice person-centered, goal-oriented care. They're the exemplars, I would say, of this way of practicing. However, they tend to only focus on 1 or 2 of the goal types. They tend to focus on mostly quality of life and a good death, ignoring the other 2, not ignoring, I guess, but not focusing on the other 2 goal types. I also think that since the four goal types are universal, that is, they exist in nature, the initial task is actually not goal setting, it's more goal clarification. So understanding how that particular goal type applies to that particular person at that particular point in time. And goal clarification, this may be a bit controversial, but I think goal clarification is most effective and efficient when the people that are involved in the process have a substantial understanding about what is possible. I don't think that this can be done by someone who then transmits the information to another person who has that knowledge. I think it's best done with a group of people who understand pretty much what's possible. And I think it's also helpful if those people who are involved in that process can have the power and authority to mobilize and direct the resources within their spheres of influence. So again, it avoids that transfer of information to another person, another group. So I therefore think it's that person-centered goal-oriented care is ideally suited to occur in a primary healthcare setting, primary healthcare as defined by the World Health Organization. However, once it's implemented in those settings, it would certainly cause major reverberations throughout the rest of the system. I don't deny that. Okay, switch to the next slide.
I've got you on process over outcomes.
Yeah, processes. So you should the slide should say should show the processes, right? Okay, or processes, as you would say. I also have become, over time, I've become less concerned about the importance of goal attainment and more concerned about the processes that are involved. The slide shows a simplified version of those processes that's easy to remember: connect, co-create, and collaborate. And I've become less concerned about getting the goals right from the start, or even over specifying the goals. I think the process of goal clarification is subjective, longitudinal, and iterative. It requires multiple adjustments over time, and the adjustments are actually oftentimes the most important part of the process. It seems to me that it also seems to me that person-centered goal-oriented care is foundational to an integrated care system. As we found in geriatrics and many other activities since then, teamwork is only possible when all of the people involved are aligned around common goals, and those goals ought to be person-centered. Now, I acknowledge, having worked on this for 30 years now, that there's substantial challenges involved in trying to implement person-centered goal-oriented care. For most health systems, even the ones that claim to provide person-centered care, it still represents a major paradigm shift. And paradigm shifts disrupt the flow of money, power, and prestige to those invested in keeping the system the way it is. In addition, there are a variety of major structural obstacles. For doctors, it's the problem-oriented medical record and billing processes, but there are lots of other obstacles. But I also think that there are increasing pressures on systems to change, and I think there's real progress being made, particularly in Flanders and in some other locations. And I'm really encouraged that the time might finally be right for person-centered goal-oriented care to emerge as the way to integrate care. It may be that you all who are listening to me today, you may be the very folks that are needed to push this forward. I'm so happy to talk to you about this.
Thanks so much, Jim. That's really an inspiring note. And briefly, I wonder, Jan, in a final reflective thought, how is this idea kind of helping to advance the work in Belgium? And Jim mentioned some work happening in Flanders.
Well, it advanced at different levels. First of all, research agenda was focusing on goal-oriented care, and I think that the PhD work by Pauline Boekstaans, who will join us later, was absolutely important in reshaping the thinking and making it an element of a research agenda. Also, the Primary Care Academy focuses now on research on that aspect. But there was also the policy level. In the federal consensus on integrated care in 2012, goal-oriented care was formulated as a very important way of dealing with problems and putting integrated care into practice. And actually in Flanders, in the framework of the primary care zones that we have organized in our primary care at the meso level, taking care, primary care zone takes care of more or less 100,000 people and brings all the organizations together. Well, within that context now, there's an intensive training of already thousands of primary care providers in the practice of goal-oriented care. And I think that's very important, also involving people, patients that have expertise from their own experience into that. And of course, there are still challenges remaining. Jim mentioned one, that's the need for an integrated record. If you go to the next slide, I fully agree with Jim. We have to make the patient personal life goals at the center of the health record, but it should be in the language of the patient, not in a kind of, well, coding or so. No, it should be the words of the patient. And then we have to integrate that, and you can click on the continuing thing. You can integrate that in the broader electronic health record, translate with the patient these goals, these life goals in objectives, and then translate that objectives in action plans, and also formulating tasks and targets in order to make that happen. And we try to solve a little bit the problem by talking, like Jim said, about life goals, which is the broad thing. Objectives is the operational strategic translation of your life goals. And finally, targets is the concrete things that you want to reach. And of course, integrating that with the health problems and medical diagnosis will be an important challenge. Next slide. And actually, in Belgium, our federal government is thinking about the conceptual definition of an integrated health record, enabling integrated care and integrating also patient's goal into that record. And I think that these are all steps that hopefully we can do in the future with people of the US, with people of Canada, but also with a lot of people from other continents, Europe, Africa, Australia, in order to really use goal-oriented care as an important driver for the switch towards person-centered integrated healthcare.
Thanks so much, Jan and Jim. What a great conversation to get us started in understanding the foundation of goal-oriented care and how it can be linked to integrated care. What I'd love is next to hear from Keith Smith, who's here to tell us a little bit from, we heard a lot about hearing from the patient and hearing from communities, and we have the wonderful opportunity to hear directly from the patient, from Keith Smith's journey that he's going to share with us today. So let's all please welcome Keith.
Okay, thank you very much for the kind introduction, and also my thanks to the organizer for inviting me. And I have to admit at first that I was a little bit surprised to talk about the issue of integrated care, because nowadays I don't have had the feeling in the Netherlands, I come from the Netherlands, that integrated care is there a very big issue. So I had to introduce myself a little bit into the topic and adapt my presentation a little bit on it. But I would like to talk with you about the art of aging with long-term conditions. And my key messages are, and that's more or less the same as what you heard already a little bit earlier, behind every patient there's a long history. And maybe that history cannot be summarized in a 10-minute talk in the speaking room from a physician or another paramedic. Then I would like to talk about aging, comorbidity, and the fear factor, and the need for coordination. I was born with a rare disease, hemophilia, characterized by spontaneous bleedings in muscles and joints, or by trauma, accidents, or operations. And when I was born, there was no treatment available for hemophilia at that time. And so my parents, I was born in 1951 at the countryside, some 50 kilometers above Amsterdam. And there you see myself with my older sister. And I must say that I experienced that period as a rather a careless period in my younger years, but the concerns were, of course, for my parents and my sister, because a little bit later in my younger years, I stayed a lot of time in the hospital because of uncontrollable bleedings in my muscles and joints. And so the first 16 years of my life, I have stayed for about 8 of them into the hospital. And it was also a period where there were experimental treatments performed on people with hemophilia, not all of them, but some of them. So my physician also advised me to use the DES hormone. Most of you will know the DES hormone, which was used for problems in pregnancy. And there were a lot of other small indications where they used it also. So DES was also used in France, Belgium, and the Netherlands in a small group of hemophiliacs to limit their growth, because they thought that would limit also the bleeding in joints and muscles. But the only result was that my growth has been limited to 145, and that's some of the unaccidental things which you carry on in your life then. Here you see a little bit medical progress in hemophilia. You see in the black and white picture in the left above a hemophilia clinic with young persons with hemophilia around 1965. And then you see on the picture on the left, right, the color picture, the generation of new hemophiliacs nowadays who can do a lot of sports and rafting on a river, which, well, let's say, the older generation could not do at their time. And at the same time, the generation of the young people who stayed in these hospital beds grow older also, and that's the picture below. So you see the different image of hemophilia in different periods of time, but you see also the difference between the young population with hemophilia and the older generation with hemophilia. My own doctoral thesis in 1979 was about humanistic medicine, and that was something like integrated care, which came over from San Francisco, where they had the Institute of Humanistic Medicine. And I described the home treatment of hemophilia and home dialysis of kidney patients, and the positive effect of dehospitalization and being treated at home. So I also learned from my physicians how to infuse myself intravenously. And in my doctoral thesis, I also mentioned Maslow's pyramid to, let's say, self-realization. And that was something like integrated care. And I also had the feeling that my physicians at that time also wanted to cure patients, to get them out of the hospital, to stay at home as long as possible, and make that journey together, and then only going to the hospital when there were problems. And I remember one time that my physician told my parents, well, we will not see your son in hospital only when he is around 60 and he is having heart problems because he worked too hard. That was the optimistic feeling that was expressed by that time, but we had some drawbacks later on. We had in the early 80s HIV and hepatitis C infections in hemophilia, not so much in Belgium and the Netherlands, but far more in France, the UK, United States, etc. And so when I sketch my life in a few minutes, then you can see that I went from many periods of unmet medical needs to good treatment. First of all, for hemophilia in the 70s, when the treatment for hemophilia became available, but with drawbacks on HIV and hepatitis C. But also in the 90s, we saw a good treatment for HIV. We saw also good treatments for hepatitis C, some 20 years later. And the consequence of all this is that I'm running from the pediatric department to the geriatric department. And that's, let's say, a positive outcome of this whole process. But you have to realize that aging people with long-term conditions have gone through remarkable transitions in life. This is my healthcare circle, as I always call it. These are the people I have contacts with in the healthcare system. And when you think about integrated care, there must be someone who is coordinating this. And in fact, I am the one who is coordinating all this by myself. I must say that every physician I have, every paramedic I have, that they are fantastic people, but it's not in their minds to coordinate all this. And when you are capable of doing this, they say, well, you can perfectly do this yourself, so let's keep it in this way. As I'm getting older, I have to deal with bad joints and muscles, stiffness after getting out of bed or standing up, limited walking possibilities, also for shopping, tiredness because of viral infections or renal problems. Most people will have limited labor possibilities or social activities, and so they have comorbidity as a consequence of aging. And so this is more or less the picture of a hemophiliac getting older. And is it then a bad picture? No, I don't think it's a bad picture. Nevertheless, there are also positive things. I use a small scootmobile to do walking together with my partner and to do shopping with her. I am on a painting course. I have a cycle, so I can cycle here in Flanders or in France or in the Netherlands. And I also enjoy, of course, family life. So nevertheless, there are the bad things, but there are also the good things. But comorbidity and aging is, let's say, creating three problems. First, there is the comorbidity and the use of multiple medications, what we also saw in the example of Jeannette from Jan. There is a lack of coordination between physicians, paramedics, which requires self-coordination. But the big issue is who can and who is willing to take over my self-management when I myself are not able to perform that task any longer. And who is also recognizing this timely, because maybe I will deny that there is a problem, but someone else will see that there is a problem. And all this together, the comorbidity, the polypharmacy and the lack of coordination is what I always say is the fear factor. It's a delicate balance, so if something goes wrong, you always fear that your life will be in the hands of somebody else and you don't know what he or she is going to do. So that's the fear factor. And who is coordinating? Is that my hemophilia center? Is that my HIV center? Is that my nephrology center? Is that my family physician? Are there other medical specialists, nurse practitioners, or geriatrics? Will there be a nurse coordinator for the elderly? Or do I become dependent on my own social network, what like the Dutch government would like to do? So in theory, we have in the Netherlands appropriate healthcare, and it is also in a kind of agreement. We also have the positive health definition in the Netherlands from Machteld Gruber, which is also adopted by the World Health Organization. But in practice, I must say a little bit that there are many pillars and walls in reality in the healthcare system, that the Appropriate Healthcare Act in the Netherlands is coming together with a lot of restrictions in access, like we have seen in the movie earlier about Ireland. We have, let's say, a lot of guideline medicine. We have growing influence of health technology assessment people. Health technology assessment will not be discussed, I suppose, on this conference. But these health economists, I think they are also worrying a lot about the cost of healthcare in society, but they don't bother so much about the real patient outcome measurements which they should apply into their deliberations. And of course, we also have in society a low labor participation of people with disablements or patients with chronic diseases. So I have some doubts about the level of integrated care in the Netherlands, and so I'm very positive surprised that there are so many of you who are thinking about the concept of integrated care in healthcare, and I would like to encourage you to go on with that. And for the people in the Netherlands, spread the word also there. It's very appropriate. So I started with the key messages, and I learned to repeat them at the end. So these are the key messages for today from my side. And if you want to know more about my publications or my paintings, you can always contact me. And I would like to thank you for your attention.
Thank you so much for that wonderful story and of your journey and where you've come from and what you're dealing with now, which I think sets up this next conversation exceptionally well. So I wonder if we can invite our panelists up to the stage. And what we've heard so far is an approach to care and a way to operationalize person-centered care by using a goal-oriented approach. What's exciting about that for those of us who've been working in this space is it offers kind of an operational and implementable way of doing something like person-centered care, which can be a very nebulous approach. And what we're going to do today is now, having heard the approach, and many of you working in the space of goal-oriented care, having heard Keith's story about his journey as a patient and all that huge circle of his care providers and how to manage the coordination, as well as balancing what's important in Keith's life in terms of painting and going out for walks and other ways that he lives his life. I wonder if you guys can respond to some of the challenges in putting goal-oriented care into practice. So I'm going to start with Dr. Pauline Boekstans. She's an assistant professor at Ghent University, as well as a family physician who's been both practicing and researching in the space of goal-oriented care for many years. And Pauline, I wonder if you can start with talking about the tensions. I guess I'll open the black curtain a little bit. In our initial conversation about today's plenary, we ended up in a really fun debate about goal-oriented care, and we highlighted all of these tensions. So the panelists are encouraged to talk through tensions today. So for Pauline, I wonder if you can tell us about the tension of being a clinician, working with your team and your patients and their families to come through a goal-oriented care approach, but then balancing that with what's required of you as a clinician to hold to clinical guidelines and other standards that you're professionally bound to.
Okay, thanks, Carolyn. Good morning, everyone. So I think as a family physician, one of the tensions is how do we define quality of care? When I started off as a family doctor, I was well aware of all the medical guidelines and then applying them to a patient with multimorbidity, as Jan showed us in the slide, was challenging. You know what to do, you know what to talk about, but the things you need to do and the things you need to talk about are often things that take life out of the conversation. You're measuring blood pressure, you're talking about lifestyle, and you kind of lose sight of the person. So when you define quality based on what's in the targets that are in the evidence-based guidelines, which are important to guide our work, you get stuck. You immediately get stuck, and that's where I found goal-oriented care very inspiring. I think, to put it on a positive note, goal-oriented care helps me to be reflexive about my knowledge and to what kind of goals the interventions I have in my toolbox as a doctor really add. It helps me to put my knowledge in perspective, to apply my knowledge to the context and the situation of the patient, to not talk about lifestyle when the patient is severely depressed, for instance, and take the priorities of the day without losing sight of the things that are still on the list for the next day. I think it helps me to be really creative in medicine. I think the patients with multimorbidity and complex psychosocial problems really challenge me to be creative as a doctor and not make a strict sum of the guidelines, and to co-create with the patient and with the team what really matters. And I think the second challenge, you want me to talk about tensions, is time. We always say that we don't have time, and I actually should be in practice now. It's Monday morning, and then I see about 12 to 15 patients between 9 and 1. So I think you can imagine that there's not a lot of time. But you don't need to do this every day and every minute. You have short, quick conversations that are very focused and that can make time to have different conversations with patients. And being curious, being reflexive, being creative is what actually makes me feel happy. Still, being a family doctor, despite COVID, despite all the challenges. So I think it will also be the way to keep ourselves engaged in care and to just have fun and do things that matter to people.
Thanks so much, Pauline. I wonder if we can now move to Dr. Carolyn Verlind. So, Pauline has talked to us a little bit about putting goal-oriented care into practice in the clinical environment and in interprofessional practice and some of the tensions that she's experiencing. You're doing some work at the regional level to put this into practice at a much higher space, but that means working across professional and organizational boundaries. Jim and Jan talked to us about the paradigm shift required in goal-oriented care. Tell us a little bit about the tensions you experience working at that level.
Well, it's very correct what you say, that it's all about a paradigm shift, and this paradigm shift needs to happen at different levels, at the patient's level and the practitioner's level, but also at an organizational level and at the government level. And so now we see in Flanders where a lot of us are already convinced that we need to change that practicing medicine and social care the way we've been doing up until now with the healthcare tsunami, or the health needs tsunami which is coming. It will not longer be possible. So we need to change, and we think that working in a goal-oriented way will help us in tackling this tsunami of healthcare needs and social care needs which are coming towards us. But how do we get everybody within that move of changing towards goal-oriented care? It's not easy, and we actually need to change in the same way and at the same time. Sometimes you see practitioners on the field who are already convinced and want to work in a goal-oriented care, such as Pauline, and we call them the early adapters. But then they need their management also to change together with them. If the management isn't ready to change, then you can't change on the field because you will not be helped by your management. And so at the regional level in Flanders now, we're trying to also convince that management needs to change and needs to change their procedures, their medical records or social records. And so it's all about convincing different levels at the same time. And so we've defined early adapters about 3 to 4 years ago, and we've talked with them and looked into their tools they've developed. And we've made little movies about those tools to sensitize the whole community, social and welfare community, about the importance of working in a goal-oriented way. And so that's the first step, sensitizing the whole health community about the importance of working in a goal-oriented way. And then the next step is giving them the tools and the possibilities to work in a goal-oriented way. And then you need the government, of course, because they, by providing tools, they need to be able to implement the tools within the way they work on an organizational level. And so the government needs to change legislation, it needs to change financing. And so these are the three levels actually you need to have implemented and need to have changed at the same time. And so now at this moment, we're really working with the early adapters. But luckily, we have the government at our side, and they're also already starting to change certain laws. They are developing an integrated care record where goal-oriented care is at the center. So we're really looking forward to changing altogether towards this goal-oriented working way.
Very inspiring to think about how you can take a clinical intervention and create structures that enable it all the way up. I wonder if now we can go to Dr. Edith Medela-Mentela. She's with us virtually today and unfortunately couldn't join us in person. I might wait for her to come up on my screen ahead of me because I've got a question for her I'd love her to join us for.
Good morning, everybody. I hope I'm clear enough.
You know what, we can hear you, Edith, but we're seeing Jim, and it's always nice to see Jim.
Oh, my video is on. I'm not sure why you can't see me.
We're doing great, guys. Now we
Okay.
Hold on, Edith. We'd really love to see you. Right now, we just have a name on the screen, and unfortunately, it's not yours. So perhaps as we're bringing Edith's image up, and I'll just keep my eye on the back room for it. Edith, if you can hear me, I do want to articulate the question for you, although I know you might already kind of have it in mind. You're doing some, we got Jim again. You're doing some exciting work in your regional area, putting goal-oriented care into practice. So Carolyn has kind of talked about setting up the structure, and you've been putting some of this into place using community health workers. And I wonder if you can tell us a little bit about some of the challenges putting goal-oriented care into the hands of community health workers who go into the homes of the community and the region. And just before you answer that, I'm going to take another look at our friends in the back to make sure that we can see Edith.
Okay, can I start in the meantime then?
You know what, yeah, go ahead, Edith, and hopefully your image comes up as you're speaking, but please do start taking us through your answer.
All right, thank you. So I work in the Department of Family Medicine, which basically is running primary health care services in this country. And we're implementing a concept called COPC, which is community-oriented primary care. So my role, as much as I'm a senior lecturer in the university, in terms of the COPC research unit, I'm actually mainly responsible for research and also community engagement. And so in terms of our model, the community health workers are very, very core, because how they assist in the system is okay, let me first of all say our model is very person-centered, and we try to work around a patient's priorities and goals. But you cannot actually elicit all of that in a clinical situation. So where community health workers assist is they go into households, they work in pairs. They go into a household, they've got a tablet with an app that helps them with the questions to do an assessment in a household. So they ask all the questions about all the family members, the illnesses, what's going on, and that information is fed into a central repository where we can then all access it. And if there's an emergency situation that needs the CHWs, those are community health workers, to refer a patient to our clinic, they do that immediately. But with the rest of the patients, we then have their profiles on the system, and we're able to look into the profile and assess exactly what the goals are. The tensions come where you find that some of the priorities of the patients are not necessarily what you can provide as a professional. And of course, we don't only assess for health challenges, but the household assessment is about every aspect. Psychosocial, educational needs, nutritional needs, and so forth. What we then do is we mobilize other professionals to actually come on board and play their respective roles. So the tensions come where the patient's expectations, for instance, are not realistic in terms of what professionals can offer. And secondly, some of the professionals, as we know, we come from different backgrounds, their goal is not necessarily aligned with our goal. And you'll have maybe the architects having a different goal, you'll have the social workers having a different goal, and so forth. So the lack of coordination and integration of all these role players is really still an issue. It's a big issue. And I know that it has been mentioned again and again that quite often we expect the patient to do the integration. Otherwise, every professional just comes in and they do what they want to do or they think they need to do. But there's integration that needs to be done at some level. And that integration really needs to be goal-orientated. It needs to take into account the patient's needs. It needs to take into account the patient's surroundings and support systems. Maybe if I can just briefly go through the 5 principles of COPC to see how it really tries to attend to patients in an integrated manner. The first principle is local and institutional analysis. So you'll be looking at what health problems they have, what social problems they have, what the environment where they live looks like. In terms of institutions, what sort of support structures are there? What other professionals are active in the vicinity, so that whatever additional you need to mobilize, we then go and mobilize from within the university. In terms of principle 2, we provide comprehensive care. So we're looking at promotion, prevention, curative care, rehabilitation, and even palliation. And that has to go through a form of a cycle, which is why we use what we call linkage of care coordination, in other words. So the primary care level, the home situation level, should fit into the primary care level. That's your clinic level. And if there's a need for the hospital to be involved, we then refer to the hospital. And we've got district hospitals, regional hospitals, right up to a tertiary hospital. And in all these hospitals, we've got care linkage officers who then make sure that when the patient finally gets discharged and they go back to the community, they are not lost to follow up. So these people will continuously do their assessments. And then
Edith, I'm so sorry, we're very short on time, and my apologies. I love that you took us through those first 2 principles. I do want to make sure that Hector gets a moment to speak, just so we're already a little bit over time. Is it okay if we leave to 2 principles for today? And thank you for taking us through the community health workers.
Let's keep it there. Although the last principle, which is quite important, is service integration around users.
Awesome.
So I don't want it to be forgotten. Thank you.
Thank you so much, Edith, for joining us and for entertaining us. We dealt with some technical issues on this end. And so, Hector, I wonder if you can wrap up our conversation. I do know we're a little bit over time. I was given the go-ahead to take a little bit more time, if that's okay, because we had a little bit of a later start. So, Hector, maybe you can round out our panel discussion thinking about some of the tools that you've been putting into practice. I know you do work in the digital health space, and you've been working in the integration of health and social care services. So maybe telling us a little bit about the tension of putting some of those tools into practice when we think about taking on a goal-oriented approach.
Yes, thank you. Let me start with a quick story, because my mother allowed me to share it here, right? So my mother is suffering from Parkinson. And she's now having already cognitive situations. So when I visited her some time ago, I am originally from Colombia, living in Germany for the last 20 years. My brother is currently living with her and with his wife. And then in one of my visits, then I asked my mother, how are you? And then she said, I'm starting to look many people in the house. At that moment, she was alone, by the way. She was living alone without my brother and his wife. So then, at that moment is when we decided that my brother should move with his wife to live with my mother. And what happened with my mother at that moment is that when I asked her, Mommy, why do you don't feel okay? And then she said, because I'm seeing a lot of people in the house. And she was already alone. I said, how many people do you see in the house? And then she said, 7 people. And what are they doing? And they say nothing, but they look at me. And I don't know if they want to say something to me. And then I said, are you scared? And she said, yes, a little bit. What do you want to do? And then she said, I would like to leave the place. And we live in she was living in an 8th floor. And then I asked her, did you ever think on jumping from the balcony or doing something like that? And then she said, not yet. So she was having cognitive issues. She was hallucinating because of an excess of medication plus her cognitive issue around Parkinson. And then we realized at that moment that it wasn't just anymore about the goals of my mother, right? So the challenge with chronic diseases, and I think it was very nicely presented by Keys and by the other speakers, is that we go with the goals of the patient, but it turns very quick to be also the goals of the family, the goals of the carers, the goals of the friends. People very much joining that journey with the patient. The journey with my patient called me and called my brother and called many other people to do something around my mother. Nobody asked my brother until recently, until we have a family crisis, not with me, but with our aunts and uncles and etc. You're not taking care of my mom, or my sister, and etc. Until we realized that the goals of my brother weren't asked. Nobody asked him, what are your goals? And then there was a point where my brother said, I'm losing my marriage. I'm sharing this because he also allowed me to do it. So I need to protect my marriage. It's getting too tight, too tough for us because we can't have holidays, we can't plan them. We need to contract out additional services. You see, we don't use the word care. We need to use those services. So who's going to help us with while we do this? And all of these type of things. That's why, and this is bringing us to technology, I am very grateful that I joined a group of colleagues 10 years ago. We started in IBM, and now we are in a new company which is called Meditive. I mean, we moved all of them out of IBM, and now we are in Meditive. But the company is still Curam. It was Curam. It is still Curam, which is a Gaelic name to talk about care. So these colleagues, the majority of them are people working on the social side, not on the healthcare side. It's social services, social protection, unemployment, family benefits, domestic violence, child welfare, creating workflows around those things. And in this team, we were handling a software for that field. Then suddenly, collectively, sharing my story and some other stories that we're starting to get, and then moving around for the last 7 years in looking for experiences and trends around these concrete things, chronic diseases and the extended team, so to say, not just the patient goals, but what are the goals of the rest, is how we arrive to the term that we say is coordinated health and social outcomes. In our team, we don't talk about integrated care because it goes too close to processes. It goes too close to care. And might be that probably my brother will not feel included in that care because it's also about him and his wife and my uncle and my aunt and my mother. So it's an ecosystem. So we realized that the most tension, coming back to the technology and what we needed to do, is how to align the different outcomes. Because we need to acknowledge the ecosystem. And there might be outcomes that are not the same, but are pursuing probably the same objective or are acting as the same person, right? So for instance, the ecosystem of my mother is my brother wants to have some outcomes for my mother, absolutely. I want to have some outcome from my mother, but my brother wants to achieve also his own outcomes, right? And we also have the organizations around them. So we have the laboratory, the lab, they want to achieve their outcomes, and they also want some outcomes from my mother, but they also need their outcomes. And the insurance company and the social security organization and the local authority. So each of them, even if all of them acknowledge the importance of the person, of the patient, they also acknowledge, we needed to acknowledge that they also have their own outcomes. Aligning those outcomes and bridging them through technology was a challenge. But I do think that with will, we can do it. Thank you.
Thank you. Thank you. So we'll wrap up quickly, and I don't need my slides. We're going to do this really nice and tight so people can go do some networking, get some coffee before their next sessions. So, what we're hearing is goal-oriented care does a few things for us that I think become lessons for us in integrated care and the implementation of it. Right, goal-oriented care is it's about sense-making. What makes goal-oriented care work is it helps to align different perspectives of the tasks and the activities that we need to do, and it helps us to do that by making the patient and their family and the community and all of those individuals kind of central to that sense-making process, which we've seen being a big challenge when we implement integrated care across professions and organizations and systems. The way we understand that concept can be very different, and going through shared understanding is foundational. Goal-oriented care is also about a process, right? And it's stress, and Jim told us this, and we heard about it in everyone's response, that what we're really talking about is not achievement of goal-oriented care. Similarly, that we don't think about achievement of integrated care, we're thinking about the process of practicing goal-oriented care. And similarly, we need to think about the process of practicing integration of care. That we're not going to arrive at this place, but we need to continuously work towards it as part of the way we think about our models of care and the way we think about serving our patients and communities. And finally, there's an interesting stress on the structures that enable a goal-oriented process. We heard that at the bedside in terms of clinical guidelines that can guide us, and all the way up to funding structures and the way that our organizations are put together that enable or disable our ability to do goal-oriented care. So it might seem that I'm just asking a person about what's important to them, but there are all of these enabling structures around that process that either can make or break that approach. So what's exciting about goal-oriented care is it not only teaches us lessons about integration, but it itself can be a catalyzer of integrated care as well. In my slides, I did have a paper to share with you, but I can share with you another time where we talk about how the principles of goal-oriented care and the practice of it can enable both our activities that drive integrated care, our functional activities that will actually make us able to do this over time, but it can also drive our normative mechanisms or the philosophies, values, and beliefs that we know are really crucial to putting integrated care into practice. So I really want to thank everybody for the conversation today, and I'm so excited goal-oriented care got a spotlight because it's such an important approach to person-centeredness, and I think potentially very foundational to integrated care. Thank you all for your extra time today.